Hi, everyone, and welcome to the American Heart Association's webinar on the current and future impacts of COVID-19. My name is Jackie Sekiguchi. I'm the Community Affairs Manager at Texas Mutual Insurance Company, and I'm thrilled to be joining with you all today. For those of you who don't know, Texas Mutual is the leading provider of workers' compensation insurance in the state, which means that we care deeply about the health and safety of our communities. And we know that the health implications of COVID-19 and how we respond to those is critical for the future of our state. That brings us to why we're here today. I'm grateful for the incredible health experts who will be joining us to outline those implications and how Austin is planning for the future. First up, we're going to have Gerald Johnson, Chief Diversity Officer for the American Heart Association, Dr. Susan Dubois, Director of Specialty Care at Community Care, and the Clinical Assistant Professor of Internal Medicine in the Department of Population Health at UT Dell Medical School. Dr. Amin Al-Ahmad, a cardiac electrophysiologist at the Texas Cardiac Arrhythmia Institute at St. David's Medical Center, and Chris Crookham, Emergency Preparedness Manager with Austin Public Health. You will have the opportunity to ask questions. Please submit those as we run through the program using the chat box, and we'll answer those at the end of the presentations. So before we get started, I want to take a moment to recognize what's happening in cities across the country. Thousands are marching in the streets in hopes that justice, fairness, and equality become a reality for everyone. And as you'll see from today's presentation, that work is critical to ensuring longer, healthier lives for all. So we'd like to begin today's webinar with a video message from AHA CEO, Nancy Brown, and AHA Board Chair, Bertram Scott.
Like you, I am heartbroken by the tragedies that have taken place across our country. The memories of George Floyd, Breonna Taylor, Ahmaud Arbery, and far too many others remain with us, and our hearts go out to everyone, everywhere, who is grieving and searching for justice. The American Heart Association denounces senseless acts of racial violence against individuals and unnecessary violence in our communities. As a nonprofit healthcare organization, we are taking a stand on social justice issues because it's the right thing to do and because there is scientific evidence supporting the link between social justice and health equity.
Racial disparities in heart disease, stroke, and other chronic conditions exist and are well documented. African Americans are also more likely to be uninsured. There is also scientific evidence that African Americans' physical and mental health is negatively impacted by the inequities that exist. Add this to the fact that in the midst of a global pandemic and given barriers to health that exist, African Americans and other people of color are disproportionately impacted by COVID-19.
The American Heart Association has championed health equity for all people for nearly a century, and we are more determined than ever to eliminate racial and class disparities. We will redouble our commitment to overcoming barriers to health and to addressing social inequalities.
We must stand together as a relentless force for a world of longer, healthier lives. That is our mission, our contribution to a more equitable society.
People are counting on us like never before. We will listen. We will drive change. We will be relentless. Thank you for your support, and thank you for listening.
Good morning, everyone, and thank you all for joining today's discussion. And as you've heard from our terrific CEO and Chairman Bert Scott, the AHA is very committed to being a partner and doing everything we can to ensure equitable health and well-being for all, and we do denounce all race and injustices for all. Today, I want to take a few moments just to lay a foundation for why health equity, for why matter are really important. We are an organization that is all about ensuring that equitable health and well-being for all occurs, and there are a lot of things that we need to consider. And today, I just want to unpack a framework around health equity and more importantly, why, so that when you hear the speakers after me and they talk about examples of COVID and how COVID-19 is ravaging our communities, you will better understand why this work more than ever is important. I also want you to know that while COVID is here, there's the work after COVID and during that we also want to spend some time on. So next slide, please. The first thing I want you to know is that access to care is critically important and it's priceless. But what we also know from an evidence-based perspective is that on a population health basis, that clinical care only accounts for 20% of one's health outcomes. And so now more than ever, when you think about our pandemic and when you think about our economic crisis and when you think about our racial and social justice issues going on in communities, now the whole person needs to be thought about more than ever. And this just shows an example of what we mean. So yes, clinical care is important, but health factors like diet and exercise and alcohol and drug use and tobacco are really important, but social factors are even greater importance when you think about education, when you think about employment, when you think about income, and when you think about family and social support. And I'll talk a little bit about more of those. And then the physical environment in which we all live, the air and water quality, housing, transit, transportation, you think about all those things. All of those things are more important collectively than just having access for care. And so again, when you think about the pandemic that disproportionately impacts different populations, I'm going to talk a little bit about that. When you think about the police and social justice issues, that disproportionately impacts folks. I'm going to talk a little bit about that. And when you think about the things that the AHA are doing, both macro and micro, we're going to share some examples of that with you today as well. So if you can go to the next slide, please. When we think about equitable health and well-being, there's a framework that allows us to think about our work. When you think about the importance of changing policy, now more than ever, things like income and housing and environment are critically important. So what role might policy play and reform in policies play? An example is if you think about livable wages. There's a lot of advocacy work, a lot of policy work being done to really continue to look at livable wages given the economy. If you think about affordable housing as an example, or the challenges of finding affordable housing, all of those things are examples of which policy can play a role. And then more importantly, when you think about the reform necessary and comprehensive nature of policy, when you think about addressing structural issues, advocacy can play a key role. When you think about breakthroughs in science and technology, we always think about technology for all, but what we now know is that when you think about equity and you think about technology doesn't work for everybody. There are places in inner cities and in suburbs and in rural parts of our country where Wi-Fi and high-speed internet are not a thing. And so it's an issue. And so when you think about connectivity, maybe there are ways that we can think about technology where income isn't a barrier. When you think about changing systems, maybe there's a system that says that instead of making all things priced the same, maybe the things that are most beneficial to us, maybe they could be, because of incentives, maybe they could be free. An example of that is, what if bottled water was free? And in every vending machine, you could always get water. Ice cold water that was good for you, that was free. Maybe a system change could enable that. Transforming healthcare, there's telemedicine, there's always innovations around how we can better create devices that can allow care delivery to be more widespread. So those are examples of what we mean. And then transforming communities, the AHA is doing a lot of things in transforming communities. A couple of examples include thinking about research. When you think about COVID-19, the AHA is investing millions of dollars now to be able to do research related to COVID and all the underlying conditions. Something we weren't doing before, something we're doing now. Additionally, the AHA has created what's called a beneficial business exchange. It's an exchange where if you have goods or services or other things that could benefit others for use, this exchange allows you to meet those people that are in need, and it's an exchange where goods and services are exchanged free to each other given these trying times. The AHA is also investing in platforms that provide capital access to organizations that are in communities that are solving the social determinants of health, including housing and food access and recidivism. And if you think about adverse experiences like trauma and things like that, the AHA, through its business accelerator and its social impact fund, is direct to community platforms enabling community transformation, as well as partnering with our regions to do great work. And I know that some of my colleagues are going to talk about some of the local things that the AHA is doing later on, so I won't go into too much detail there, just to let you know that nationally, the AHA is thinking about this, and then regionally and locally as well. Next slide, please. One of the ways in which COVID-19 and our economic impact plays a role is regarding poverty. And when you think about the markets that all of you are in, using Austin as an example, as wonderful and as terrific and as great as the city of Austin is, you may or may not know this, but it's the most segregated economically city in the nation. Said a different way, poverty plays itself out in ways that means that there are haves and there are have-nots. I'm sure you all are familiar with that, but when you think about low income also translates into poorer and poorer health conditions, examples that lead to high blood pressure and things that impact the most vulnerable in the communities everywhere. The other way that I'd like you to think about this is if you think about an equal approach, an equality approach to things, you would give everybody the same. What we've learned about equity is equity thinks about each person based on their needs, and the graphic to the right shows you that if you treat everyone the same, the person that already had benefits continue to have benefits. The person that may have needed a little help is now in a better place, but the person that needed the most still is not able to enjoy the benefits of others. And so an equitable approach is ideal. Other than equitable, the other thing that you could do is just eliminate the issue altogether. Next slide, please. The other thing worth noting is that when you think about poverty also has a lot to do with housing. And when you think about the Eastern Crescent as an example, your zip code has a lot to do with your health. And what I want you to know here is that when you think about what's going on in Travis County, when you think about the disproportionate impact that race and equity play in the county, I want you to know that poverty disproportionately are impacting our Latino and Latinx brothers and sisters, as you can see here, almost 26, 27%, and African Americans almost 23%. And what that means is that instead of being able to live in the center of things, they're being displaced into communities outside the city, to the north, to the east, and to the south. And why that matters is that the quality of services are different depending on where you live. I'm sure that's no surprise to any of you, but if you think about Runberg or St. John's or Manor, all of these different neighborhoods, all of them are neighborhoods where poverty is disproportionately impacting our Latinx and our African American populations. Next slide, please. Finally, I just want to pull it all together for you. I opened by saying that when you have a pandemic, when you have an economic crisis, and when you have racial and social justice issues rampant, life expectancy has a lot to do with that. And so poverty plays a role in that, housing plays a role in that, adverse conditions like stress and trauma play a role in that. And this slide just shows you that when you think about physical geography, when you think about access to care, when you think about culture, when you think about systemic factors, When you roll that all together in Austin and its immediate surrounding cities and neighborhoods, I want you to know that there's almost a 20-year life expectancy difference. And I want to pause there just for a second, and I'm going to repeat that. A 20-year life expectancy difference in the best neighborhood versus the neighborhoods where poverty and housing and transportation and other environmental issues are greater. And so when you think about the work that the AHA does, now more than ever, taking an equitable approach to one's health and well-being is critically important during COVID and after. And I'm delighted to be with you this morning, but I hope that gives you a sense of why equitable health and well-being are important, and more importantly, why the AHA now more than ever is a critical partner in playing a role in addressing these issues. Thank you.
Thank you so much, Gerald. I'm incredibly blown away just by the simple fact that our zip code can determine whether or not we have an extra 20 years with our loved ones. And I really appreciate you being with us today. Gerald, I know that you have to pop out a little early today, so I want to make sure that I ask you a specific question that I think is on a lot of our minds. You know, as we're seeing social unrest, as we're all reflecting and thinking about how we can do better for communities of color, as the Chief Diversity Officer for a national organization, what advice do you have for all of us and everybody on the call?
Well, I don't know that it's advice, but I'll tell you what I'm doing. I am seeking to be a part of making things better. I am seeking to learn as much as I can about the issues. I'm seeking to share what I'm learning with as many people that will listen. I am passionately challenging those around me to be more aware. And then, like our organization, I denounce racial injustice for African Americans and others. I also would like everyone on this call to think about the importance of different things that we can all do, and think of them all almost like medicine for something that's bad. And in our nation right now, our nation is in a bad place when we think about equity, when we think about race, when we think about equality. And so the medicine for our country is probably going to be in various stages. One of the medicines, or one of the prescriptions that I think is important, is that we are all very civically conscious and participate in civic engagement. And so what do I mean by that? I think that the census is incredibly important. I think that voting is incredibly important. I think at the local levels, now more than ever, being aware of how civics work is tremendously important. I also think that when you think about medicine, I know that making sure that reform, when you think about policies, when you think about advocacy, really looking at the root causes of things as opposed to maybe the symptoms. And the example I like to give here is that oftentimes if you have a headache, you may get in the habit of taking aspirin to make the headache go away. But if you know anything about your body, when you have a headache, it's usually your body's opportunity of telling you something else is wrong. And so yes, the aspirin makes the headache go away, but if you never address the root causes, chances are that headache is going to come back again. And so I would ask all of you to really think about the great work that you do, because you all are doing great work, but not only think about addressing the symptoms, but really asking yourself, yes, short term, maybe how can I address a symptom, but longer term, what can I do to be a part of addressing the root causes, the systemic causes, the legacy causes of the issues that are creating the problems, so that we can have equitable health and well-being for all.
Thank you so much, Gerald, and thank you for being here today. At this time, I'm now going to invite Dr. Susan Dubois to turn on her camera and unmute her microphone so that we can begin our next presentation. I also want to take a moment to remind our attendees to post your questions in the chat box as we go, and we will answer those at the end of the program. Dr. Susan Dubois is a Director of Specialty Care at Community Care and the Clinical Assistant Professor of Internal Medicine.
To the American Heart Association for the opportunity to share Community Care's experience during this pandemic. We've heard the word unprecedented a lot in the last several months, And I can't stress enough the importance of the unprecedented collaboration and coordination with our community partners at Austin Public Health, at UT Dell, at Central Health, and at the American Heart Association, to name only a few, which have allowed us to test almost 8,000 people in Travis County and the surrounding areas. If you could advance to the slide, please. At our drive-up and walk-up facilities, we provide education and testing according to the CDC guidelines for all people, regardless of their insurance status and without any barriers. Our external-facing COVID-19 hotline directs people to the closest testing center and connects them to appropriate medical care. Now, we've seen an overall positivity rate of 18.1%, with 23% positivity in people who have symptoms consistent with COVID-19 and 4.4% in those without any symptoms or known exposures. The Hispanic Latino population in Austin has a significantly higher rate of positivity compared with other ethnicities, possibly due to challenges posed by employment in essential businesses such as healthcare, construction, sanitation, transportation, as well as cohabitating with multiple generations in the same household, ride sharing, and language barriers, which may have delayed education on how COVID-19 is spread. African Americans in our setting have a positivity rate of 6.6%, which is closer to that of non-Hispanic whites, but they're underrepresented in the total number of tests obtained, making up only 7%. Understanding that our African American patients are at higher risk for severe forms of COVID-19, our community health workers are working to identify and address social determinants of health in this high-risk group. And finally, telehealth and remote monitoring of blood pressure and blood glucose hold promise for safely controlling risk factors for COVID-19 in our vulnerable population, as well as utility beyond this pandemic. Next slide. Drive-through at our testing Hancock Center in mid-Austin started on March 17th. We chose the drive-through methodology, as did others, to reduce the risk of exposure to our staff and to conserve PPE. However, as the Texas heat bears down on us, we're moving this testing inside and exploring options for that. Patients who visit our testing sites are screened for symptoms and exposure. They're provided with education, and they're entered into our database, which is shared with UT Dell and Austin Public Health for contact tracing. They're also given a telehealth appointment with primary care team for medical needs and symptom follow-up. Next slide. We quickly realized that we needed to bring testing into the Eastern Crescent after we noticed that many people who were showing up at Hancock came from West Austin and found us through the hotline. Thus, we deployed our mobile unit to Barbara Jordan Elementary, Hornsby Dunlop Elementary, Manor High School, Southeast Metro Park, in addition to adding walk-up testing to our Pflugerville and William Cannon clinics. These sites also are testing according to CDC guidelines, so that means that patients coming to those centers need to have symptoms or exposure history. In April, in order to better understand the positivity rates amongst our population, we began offering testing to all patients, regardless of symptoms or known exposure. Finally, there was a cluster identified at the Salvation Army in late March that highlighted the need that we needed to bring more testing to our homeless population. Next slide, please. I'm now going to describe some of the work of my colleague, Audrey Kwong, and her team. Audrey's our Associate Director of Community Engagement and Health Equity. Audrey leads our homeless clinics, and in April, after the Salvation Army cluster was identified, her team brought testing to the Arch and identified an additional 5 positive individuals who were then relocated to the EOC isolation facility. They then went back to the Salvation Army and tested all the rest of the women in that facility, identifying another 14 positive individuals, notably half of whom had no symptoms. At that point, all persons were placed in isolation or protective lodges for symptom monitoring, and subsequent surveillance later in April did not indicate any more positives, indicating successful containment of that outbreak. Next slide. So here's the testing at the Arch setup. There are 2 tents. The first is where demographic and symptom data are collected, and the second is where the nasopharyngeal swab is collected. Next slide. We've also extended testing into the state camp near 183 in Montopolis, which is a 6.7-acre state-sanctioned homeless encampment that currently has about 188 residents. Next. Another initiative is our door-to-door cart, shown here at the Riverside apartment, a 12-story, 164-unit apartment with a high prevalence of elderly and disabled individuals with multiple chronic conditions. In all, our homeless team has performed 444 tests on both sheltered and unsheltered in order to limit outbreaks in this highly vulnerable group. The next slide shows the isolation facility at I-35 and 290 run by the EOC, which has a 204-person capacity for persons who are either known COVID positive or are under investigation due to symptoms. The EOC also has 4 protective lodges for persons at high risk for severe COVID-19, such as individuals on chemotherapy or hemodialysis, or people without symptoms who've been removed from congregate living centers while awaiting test results. All persons at these facilities receive 3 meals a day, check-ins twice a day, and medical care is needed. Next slide. I'm switching gears now back to our CUC laboratory testing dashboard. As of this morning, we've tested 8,496 individuals with an overall positivity rate of 18.1%. We're performing about 200 to 250 tests per day. In the lower left-hand panel, you'll see the rolling positivity over the previous 7 days, which was 21.5% as of June 6th and 18.5% as of this morning. The next slide shows our positivity rate by rate and ethnicity, which is highest in those who identify as Hispanic Latinx. Out of 4,306 tests, the positivity rate was 24.9% and 32.7% in those who have symptoms consistent with COVID. Among Latinx without known exposures or symptoms, the positivity rate is still 6.7%, and that's in that last column over there. And that's more than twice that seen in African Americans and 5 times that seen in non-Hispanic whites who similarly had no exposures or symptoms. Significantly, as I said before, African Americans represented only 7% of the total test, despite making up 9% of the Austin CUC population, indicating that they're less likely to come for testing. Next slide. In order to reduce COVID-19 risk for our staff and patients, we shifted to telehealth on March 19th. In the months of April and May, about 65 to 75% of our overall care was via telehealth, predominantly telephonic, as our patients have significant barriers to video visits, lacking smartphones, unlimited data plans, or access to Wi-Fi. We're currently in the process of bringing back in-person care for our diabetic population. These patients have the highest needs for in-person care, labs, blood pressure, foot and eye screenings, but they're also at the highest risk for COVID-19 and afraid to leave their homes. So we've had to do extensive education about social distancing in the clinics, as well as bundling in-person care, meaning we close as many care gaps as we can in a single visit, and then maximize their value of telehealth by adding remote monitoring of blood pressure and blood glucose. Next slide. Our pharmacy team has been critical to assisting our patients with chronic diseases, mailing out 80% of prescriptions directly to patient homes and adding curbside service for the rest. And finally, in a collaborative effort with the American Heart Association and Central Health, we've provided blood pressure monitors to 1,000 pregnant women, thus reducing their need to come in for prenatal visits and increasing their engagement in their own health. Similarly, we've mailed blood pressure monitors to patients with uncontrolled hypertension, identified through our population health dashboard. All patients receiving blood pressure monitors are called by clinical pharmacists to ensure proper usage of the meter and adjust their medications as indicated. And that is the end of my prepared remarks, and I thank you for this opportunity.
Thank you, Dr. Tumora. Those stats are both incredibly telling and heartbreaking, and we appreciate Community Care's commitment to our vulnerable population in Central Texas. Thank you for being here. This time I'm going to invite Dr. Al-Ahmad to turn on his camera and unmute his microphone while I begin introducing him. Dr. Amin Al-Ahmad is a cardiac electrophysiologist at the Texas Cardiac Arrhythmia Institute at St. David's Medical Center, and he's the board president of the American Heart Association in Austin. He has seen the impact of COVID-19 as fewer are seeking care for heart attacks, strokes, and cardiac arrest, both nationally and right here in Austin. Dr. Ahmad, thank you for joining us.
Thank you very much. It's a real pleasure to be here. Let me see if I can turn on my video. I just need the host to allow me to turn it on. It's a real pleasure to be here, and it's a real pleasure to work with the AHA and to see the leadership on what's going on, both with COVID and with respect to what's happening in general in our country. So I'm really delighted to be here. If I can get the slides pulled up. What I wanted to talk to you about a little bit, I wanted to share with you a story of a patient first. And I think it kind of puts things in perspective, because it's really not just the story of one patient, it's a story of a lot of patients. And so this is a real story. This is a patient who, is in his 60s, has a pacemaker, and was experiencing some chest pain. Well, so the gentleman called the doctor's office, but didn't get a very quick response. And one of the reasons is that, like other businesses and other platforms, doctors' offices are now, some of the folks are working from home. And so response times have changed from before. And so the patient called our office because they have a pacemaker and said he was having chest pain. We advised him to go to the emergency room. And he said, I am not going to the emergency room. Absolutely not. There's COVID. I'm very afraid of that. Ultimately, he came to our office, and just in the waiting room, he was profusely sweating, having active chest pain. And we wheeled him down to the emergency room immediately, and he was in the throes of a heart attack. And this is just one example. And unfortunately, in the hospital, over the last few months, what we've been seeing now is that when these patients do come in, they're often sicker, and they're in worse shape than we've seen in a long time. And in large part because they're delaying going to the hospital. They're fearful of coming in. They're fearful of calling 911. They're fearful of seeking treatment. So this is really one of the major effects that we're seeing, and something that has me very concerned. Another thing we're often seeing now is when we're telling patients, hey, you have a serious heart rhythm abnormality, and we think a procedure might be the best way to go, or initiation of a medicine in the hospital. Again, we're getting this response of fear. And one of the things we're trying to tell people is, your risk of the arrhythmia or your risk of the heart attack may actually be higher than your risk of contracting COVID and then dying from COVID. And so that's a hard thing for patients to understand. Now, it's a domino effect, right? Because, we have this fear of getting treatment, calling 911, but there's also now challenges, in particular in the elderly, of getting healthy food, getting supplies, getting prescriptions. People financially are having issues. I've had to fill out more forms to get people free medications than I have in a very long time. The supply of samples in the offices has been cut down. Our ability to get patients drugs has been a challenge. People are under stress, and that creates a lot of unhealthy eating habits. And so another domino is falling. And so, we all kind of joke a little bit about it, that everybody's in quarantine and they all gained weight because now everybody's starting to bake or do things. But in reality, it's an issue. People are losing weight. They're much less active. And so patients who really need that daily activity are kind of in an apartment or in a small home or wherever, and they're just kind of pacing back and forth. They're unable to get to the gym, unable to get outside and do exercise. And some people are too afraid to leave the house and do many of these things. So physical activity has gotten significantly lower. The other thing we're seeing, and I mentioned this earlier, is the issue of financial difficulty with unemployment. We're starting to see people lose access to healthcare, be it loss of insurance, financial strain, difficulty to purchase medications, transportation to the hospital or to the doctor's office. And then one of the other things that I think Mr. Johnson had brought up was that the disparity financially is significant because, you know, now we're pivoting towards telehealth, and for heart doctors, we often would like to see what rhythm the patient's in, and there are technologies that are able to do this. An example would be the Apple Watch, and there's some other technologies that are less expensive than Apple Watch, but still it's a financial burden if I have to tell the patient you need to purchase a heart monitor so that we can monitor you at home. It's another financial burden on these patients. So unfortunately, I think that we're concerned that this kind of domino effect is going to start to lead to a lot of potential future problems, that all will have a bigger health effect for months or even years to come as we move forward from this. Heart attack, heart disease, stroke, and unfortunately, again, when people show up in the hospital, they're showing up a little bit later. Can we go to the next slide, please? So one of the things we're also seeing is sort of the statistics. This is really sobering data, and this is not just in the US. This is something we have seen in Europe. There's been reports of this, that there's a significant decrease in hospitalizations, 911 calls, across the board, heart attacks and strokes and so forth. And it's not because these cases are not happening. It's not because people have stopped having heart attacks or stopped having strokes. It's because people are no longer calling 911. So nothing stopped for COVID. Unfortunately, what has stopped is people's calling 911, getting early care. We're seeing reports of, problems, heart problems that we have not seen in 20 years because of people waiting too long. All the gains we've made of early response to heart attacks, early response to stroke, a lot of that has gone away, unfortunately, because of this fear of catching COVID. So that's been a real issue for us. I think that kind of summarizes my main concerns with this. I think that we're hoping that things get better, and as people hopefully start to understand the problem a little more, and we try to reassure people. And again, it's a heterogeneous effect. Not every place is affected the same way. Not every location is going to be the same. And there's a lot of disparity in terms of access and healthcare and all sorts of things that make this a little bit more challenging. But this is going to be, I think, a problem for some time to come. And I hope that we can start to work on solutions for this and figure this out a little bit more. I don't have anything else to in terms of this. I think this is my main concern.
Thank you so much, Dr. Al-Ahmad. We all very much appreciate your leadership and your commitment to fighting heart disease in our communities. At this time, I'm going to invite Chris to turn on his camera and unmute his microphone so that we can begin our next presentation. I also want to just take one last reminder for our attendees about the chat box. We are organizing your questions and we'll answer them soon. Chris Crookham is the Emergency Preparedness Manager for Austin Public Health. I imagine he's been pretty busy over the last few months. Chris and his colleagues have been working hard to help residents stay safe, and now they are laser focused on planning for the future. Chris, take it away.
Thank you. Thank you for having me. Again, I am Chris Crookham, the Public Health Emergency Preparedness Manager for Austin Public Health, and I've been in this role for about 3 years now. And prior to this position, I was also in public health, emergency preparedness, just as a program coordinator. Next slide, please. So broadly speaking, the main point of public health emergency preparedness is to prepare for, respond to, and recover from public health threats, emergencies, et cetera, that affect the public's health. Put in layman's terms, what I like to say is we prepare for things we hope never happen. And then if they happen, then we're as prepared as we can be to address that disaster. So some of our main goals overall in our day-to-day work is to train and educate our coworkers, our employees, since they're usually the first pool of people we will pull from when we need to respond to something. But we also work with our partners, such as police, fire, EMS, public works, but also nonprofits like Salvation Army, Red Cross, et cetera, so that we know each other all the time, and that when we have to respond to something, we already know who we're working with and we're not having to make introductions on the fly. And additionally, we're able to let them know what our responsibilities are and what we can do, but we're also able to gather feedback from them in terms of what they think we are supposed to be doing. That way we can set expectations and ensure that all needs are met, that we can, again, work together seamlessly during a response. We also plan for and prepare supplies and our personnel, not just for training, but we have meetings throughout the year. We have trainings and exercises that we put on just to give people experience responding to something in a non-threatening way. That way they can learn and be as prepared as possible for when the real thing happens. And then we also have, supplies, limited supplies of emergency items that we may need so that we can respond as quickly as possible, and then order some things to backfill as we need. And then really the ultimate goal is just to reduce threats and long-term effects on people's health from disasters. Usually, generally speaking, when we respond to a disaster, the response itself is actually pretty short. And depending on what the situation is, but if it's like a flood here in Austin, or if we're hosting evacuees from the coast because of a hurricane, there's a definite time limit, more or less, of when we can expect for them to go back to where they were and not needing our response anymore. However, there's also the long-term recovery part of that actually usually lasts a lot longer than the response. COVID-19 has been a bit different in that it's a very long response, so we're still in the middle of that response, but we do expect the recovery to be even longer than we would normally expect. Some of the things that we do on a day-to-day basis to help protect the community and prepare for things that may occur include monitoring biological agents, so things that shouldn't be out there, like maybe anthrax or something. We want to be able to detect that as quickly as possible and be able to respond so that we can reduce the impact that may have on the community. We also look at hospital data on a daily basis to see if there's any uptick in any particular prodromes, such as respiratory issues. That way we kind of have a heads up that there may be something out there, and we can do some research into what that may be. We have several planning documents that we work on throughout the year and that we update on a regular basis. We have plans that address mosquitoes, mosquito-borne diseases. We have plans that address hurricanes and cold weather and hot weather. So we're prepared for a wide variety of potential disasters and emergencies that could arise. We operate out of our department operations center whenever we have a disaster, and that's kind of just where we coordinate the entire department's response. So it's my team's responsibility to ensure everybody has the tools and resources they need so that when they go out there to respond, they're able to respond as best as possible. And then specifically, usually when we're sheltering individuals, some of the main things we do include providing disease surveillance. So we go out there, make sure people are staying healthy, and if anybody is sick, we're trying to isolate them and provide them care so that they don't spread that within the shelter. Because something we often say is we don't want a disaster within a disaster. And so if we were to serve food, that hadn't been inspected by our sanitarians and that got people sick, obviously that would be a big issue that we'd have to deal with. So we want to be as proactive as possible when we're serving members of our community, and especially those outside of our community as well. Just some successes that we've had and some responses we've done over the past few years included responding to Ebola, responding to Hurricane Harvey. During the boil water notice in 2018, we activated 2 multi-agency resource centers, which are really just one-stop shops for individuals who survived the disaster, where they can go to get resources from nonprofits, government entities, and even private entities if they have something to provide, such as food assistance, rental assistance, etc. Annually, we monitor the air in hospitals during South by F1, ACL, and occasionally other large events as requested. We conduct extreme weather surveillance. So actually last Wednesday, we put out our first heat report for the summer, and those will be coming out on a weekly basis now. And they just kind of summarize what the temperatures have been and what the effects have been on the community, how many people have gone to the hospital because of heat exhaustion, how many drownings or near drownings have we had because people are swimming more. So we just kind of keep an eye on that. And that helps us inform us on our messaging out to the community. What do you need to be aware of? What do you need to take into consideration as you're going outside and living your life? And then in order to assist that, we also go out and we try to do at least 2 community events per month, just to let them know what we do and help them prepare themselves. We haven't been able to do that lately. We've been busy with COVID-19, but generally speaking, we do about 2 events per month. Next slide, please. So specifically during this pandemic, COVID-19, we've done a whole host of things, and we've gone through a lot of different iterations through our response because things have just been changing constantly. So when things were first starting to occur in China, we were watching the news, watching what was going on over there, but there weren't necessarily any steps we needed to take just quite yet. And then thankfully our interim health authority, Dr. F. Scott, has been pretty aggressive in his approach to this whole pandemic. And so on February 5th, we activated our Department Operations Center, which that will be 18 weeks as of tomorrow. We've been activated in response to this emergency. In the beginning, we were mostly just receiving flight manifests from individuals who were coming from China and then eventually Italy and Iran as well. We would collect their information. We'd reach out to them, talk to them twice a day to get their temperatures and check their symptoms. We'd send them health authority order letters that told them, you couldn't leave your home, you couldn't do this, you couldn't do that, etc. And then we've done lots of testing, community site testing, which we are very full this week. We have over 500 people signed up each day to get tested. We've done lots of mobile testing for people who are immobile or to do pop-up testing. And then we had that mandate from the governor to do nursing home testing. And so we are actually finishing up going through all the results from the nursing home tests that we got back. We also have a medical hotline that's been sent up from the beginning. Originally, it was taking calls from medical providers looking for advice. And now it's mostly just community members calling in for questions that they may have. And our EPIs have been super busy, as I'm sure you can imagine, doing lots of case investigations. We're starting to ramp up our contact tracing now, and we're investigating lots of different clusters that keep popping up throughout the community. And then our social services have been super active as well, providing guidance and assistance to daycares, priority populations such as construction workers, minority populations that are most affected, and then of course people experiencing homelessness as well. Next slide, please. And then as to the future of public health, I'm actually kind of excited to see what happens. These are just some things on the screen that I kind of had in mind, such as I think we'll see a big emphasis on hygiene for a while, trying to educate individuals on not just how to protect yourself from COVID-19, but from any disease that's out there. So washing your hands, I think we'll see more hand sanitizer out. I think we'll see more technology to help combat diseases. I think social distancing is here to stay for a while. I think it'll be interesting to see how we deal with concerts and football games and the trail of lights, while maintaining social distancing and face coverings. Some of the plans that we have that we're having to retool already include cooling centers. So today we're having triple-digit weather that may require cooling centers. So what does that look like, fitting fewer people in with social distancing, masks, taking temperatures? Hurricane season, while we're not directly affected, we do receive evacuees. So how do we shelter them? And then eventually there will be a vaccine available, ideally. And so part of our responsibility will be to provide that vaccine to community members. So we'll have to do some planning on how we're going to do that. And then of course, lots of people are requesting guidance for this and that. There are things we haven't encountered yet that I'm sure will require guidance. So just as we're going about our business, we'll have to be providing guidance for a whole host of things. And then just finally, I'd like to say that as the former response to COVID-19 kind of dissipates and we go back to our normal jobs, we will have to incorporate COVID-19 into our work. So we'll continue to see cases, we'll continue to have to follow up on that, but that will just be our day-to-day normal and no longer an official response. And that's all I have. Thank you.
Thank you so much, Chris. I definitely feel safer knowing what all is going into making sure that our communities are safe and healthy going forward. Before we get to Q&A, I'd like to ask Joel Rice to unmute and turn on his camera for just a quick 2-minute talking points about what's happening, what AHA Austin is doing here locally. We're going to start compiling questions, so if you haven't submitted those, please do that. And we'll get to that shortly. Joel?
Great. Well, thank you to all of our panelists and to everyone being here today. I'll keep my remarks very brief. I wanted to just share a little bit on a national and local level of how the AHA has responded. So at the beginning of the pandemic, the AHA announced $2.5 million specifically in these fast response research grants to help us better understand the coronavirus and its unique interaction with the body's cardiovascular system. They have been noticing some really unique cardiovascular symptoms that could have very long-term implications on patients. And so very proud that the AHA was able to respond in that way. We've also been a tremendous resource for families, students, and workplaces to understand how to minimize the risk, how to stay active and eat healthy at home. As Dr. Al-Ahmad mentioned, many patients don't have access to the gym or they feel uncomfortable going outside. So how can they eat healthy and also get that physical activity at home? And also, we've been a tremendous resource for people that have cardiovascular conditions because we know that they're at an increased risk. And I want to share just a little bit, if you'll flip the slide, I'll just run through these really quickly in terms of some of our local response. And so we've been focusing on helping our community in a couple different ways. So of course, trying to increase our assistance to hospitals, specifically our rural hospitals for the treatment of people without health insurance, expanding telehealth and providing resources to our clinics who are providing those telehealth. We have incredible programs that focus around blood pressure management, cholesterol management, and diabetes management. And what we're seeing is a lot of those hypertensive patients were not able to get into the clinics. And so we partner with a lot of local clinics to provide blood pressure cuffs and resources, as well as additional resources and materials so that they can provide to their patients to help measure and monitor their blood pressure at home, as well as when to seek help if their hypertension is not under control. Will you skip to the next slide real quickly? We're helping in several other ways. Of course, we've teamed up with United Way to focus on building food pantries and childcare centers to ensure that children will have food outside of school. We're partnering with 3 local independent school districts to install hydration stations so that when kids do get back to school, they'll be able to have access to clean drinking water. We're focused on ensuring children continue to be fed with nutritious meals. And then we're focused on increasing access to the Supplemental Nutrition Assistance Program. As you know, a lot of families are going to be needing this, and it's going to take a while for this recovery to happen. And so focusing on supporting policies that will allow more families to have access to SNAP and longer access to SNAP. So that is what I have, and I will keep my comments as brief as that because I know we want to get to questions. So Jackie, I'll turn it back over to you.
Yep, thanks, Joel. Okay, we're going to try and squeeze in 2 questions so that we can end on time and get you back to your busy days. One question that came through was, I had read previously that we should aim to be under 10% positivity rate in order to know that we are doing enough testing. Can you speak to future plans regarding increased testing? Chris or Dr. Dubois, do you think you could speak to that?
I can mention something real quick. I do know that we are working on increasing testing quite a bit. We've opened up our testing hours at our current testing site, and we're finalizing a contract with a vendor to go out to be able to do pop-up testing, to go to individuals' homes to do testing. So people who are immobile, who can't get to our site or who don't have a car, we're trying really hard to get to those populations and those individuals so that we can provide testing to everybody.
Great, thank you. Dr. Dubois, do you have another answer for that?
No, you can get to the next question.
Great. The next question is, our medical director, Dr. Mark Escott, was recently quoted as stating that in order to address the health disparities, we must invest in public health priorities such as preventative medicine and care for such common ailments as diabetes, hypertension, cardiovascular disease, and obesity, which increase the risk of death for those with the virus. How should our local public health department do this? What additional policies should City of Austin adopt?
So I don't know that I can speak specifically to all those points, but I will say broadly, I think that is part of the future of public health. I think we will have to do a lot more outreach in terms of our chronic disease programs. We already have chronic disease as a focus, but I think that focus is kind of narrow. So I think we're gonna have to broaden that and reach out to even more populations so that we can address many of these issues, as Dr. Escott has pointed out.
Great.
I would just say that at community care, we're also taking a population health focus. So reaching out through registries to patients who have fallen out of care or are not meeting goals for regard to blood pressure and diabetes control, and then addressing their social determinants of health, as well as making sure they have the needed medical care and access to medications.
Great. One question for Dr. Al-Ahmad and Gerald. What do you believe is the most important thing the AHA has done in response to the COVID outbreak?
Maybe I'll let Gerald start. I can say one is at least get information out. I think that's been extremely helpful for not only practicing physicians, but also for patients, that this is a good resource. Things like know your symptoms, know when to call, things like that are very, very helpful, not just in a situation of a pandemic, but in general. But I think getting the information out has been probably one of the biggest things that's been helpful from from the practitioner as well as from the patient's perspective. In the medical journals that we read, we're seeing updates constantly about how COVID-19 affects the cardiovascular system and keeping us up to date in terms of how to treat these patients from the heart perspective, as many of them do have cardiac complications of COVID. So that's been extremely useful from our perspective.
Thank you, Dr. Al-Ahmad.
And
All
Jack,
right, well,
Gerald had to jump off, but I also just wanted to say that people know that when they come to the American Heart Association, when they see things online, that they can count on that information being accurate and up to date. And so we have been a valuable resource for businesses and community leaders as being a trusted source for information when there's so much noise going on and so much misinformation being communicated as well.
Yeah, thank you, Joel. All right, so we are now at the end of our program, 12:30 on the dot. Thank you so much for all of you for joining us today. I'd like to give another special thank you to all of our incredible presenters. If you're interested in learning more about the health equity efforts of the American Heart Association, please follow them on social media at AHA Austin. Thank you. Stay healthy and safe out there and have a great rest of your day.